It's for the record. So,
It's a technical thing.
it's a technical thing. So, the next bit, guys, we are going to go through COPD. We are all seen patients with COPD? I know, right? I don't know. You know? Yeah, it's one of. It seems to be like a quite a common typology of patients that we get of varied degrees. People that tell you, yeah, I've been diagnosed with COPD, but you know, other than a little bit of difficulty in breathing on exertion, not a huge amount. Up to the patients that they can literally in the morning, they really struggle to get from the bed to the chair in the living room, and that's them until the evening. And in the process of trying to get from the bed to that chair, they had to call 2 ambulances because they couldn't handle it. So it's unfortunately it's quite a COPD is a degenerative disease that you don't get better. We can manage it, but our patients will get worse and worse. So, because it's such a high prevalence of patients that we get, we thought of including this in our respiratory conditions day and actually get a little bit into the whole depth of what is COPD, what does it do, why do our patients experience what they do, and what is our treatment, what is the best treatment for our patients with COPD, and maybe in the process burst a myth or two about COPD. We'll see. We'll have a lovely discussion over it. So, what we're going to do, we are going to revise the basic pathophysiology of COPD. And that gets me quite nervous because I'm going to live draw it like Colin did, but I'm not capable of drawing like he does. So, just bear with me on that one, okay? So, we're going to describe and discuss the subtypes of COPD. And then we are going to discuss respiratory failure in general at first. And then we're going to try to attribute it to in the context of COPD. So what is respiratory failure? What does it mean? What types of are they? And how does it relate to COPD? Is that important? Is it not? Kind of thing. So we're going to have that discussion together. So firstly, what is COPD? So this is, hopefully, this is just a revision slide for you all. It's a type of obstructive lung disease in which chronic poor airflow and inability to breathe out exist. So we are going to introduce the concept, well, hopefully sort of reintroduce the concept of air trapping. And I'm going to show you in details how does that happen. COPD shares some inflammatory pathophysiology with asthma, but, so some things I said about asthma was introducing some concepts here and vice versa, but the difference is that your acute asthma exacerbation is reversible, while your acute COPD exacerbation is manageable. COPD really in itself is not, and it's just going to keep on getting worse. COPD principally includes these 2 conditions. I hope you're all familiar with that. Is chronic bronchitis and emphysema. That's what COPD is. It's your chronic obstructive pulmonary disease, which is chronic bronchitis and emphysema. That's what COPD is. So let's talk about 2 seconds about prevalence and epidemiology. There is 2,500 new diagnoses in Scotland per year of COPD. So you can see how there is a constant increase of pressure on our service for COPD patients, but also in the wider NHS, because it's a condition that we know we can manage and we can confer to our patient a better quality of life, but it's an ongoing care for a long time. Yeah. Therefore, we get associations like the community respiratory teams. Any of you familiar with them? Yeah, community respiratory teams, excellent at what they do. Well, back in my days, we used to do placements with them. Any of you that did any of the placements with them as technicians? No, we don't do it anymore. Okay. Fair enough. Try this. All right. And they do a wonderful job. And the whole point of it is attempting to manage the patient at home the best they can. And they're wonderful at it. Try to reduce the number of ambulance calls in COPD patients and try to reduce hospital admissions. But they're different, similar bodies that aim at the same thing, because the pressure on the wider NHS from COPD is increasing every year. There is somewhere around 3 million COPD patients across the UK. And that is the thing, isn't it? Like, none of them that we can put through a process where they're going to heal, get better, and then be seen. So it's the patients that we're going to see on the long term. Prevalence increases with age and dramatically runs up in over 50s. Okay. So what causes COPD? Why do you've got so many patients with COPD? What are my risk factors of COPD? Well, exposure to tobacco products accounts for about 80 to 90% of all cases. So about 90% of, 80 to 90% of the patients who go to their COPD would have been caused by exposure to, smoking or exposure to cigarettes. Passive smoking is the other one. This is people that have worked, for example, in the hospitality industry for a long period of time before the smoking ban. I used to work the doors just before the smoking ban started, and I mean, just going into a pub, at the time, you all remember it, just going in, that is just so much like curtain of smoke going in. So you can imagine, and I was lucky enough to be outside, but you imagine like people that worked in for long shifts inside at the bar, you can see how much smoke they could actually be exposed to over a few days. Occupational exposures to hazardous gases, so carbon monoxide and other types of smokes and irritants. There is a study that is looking at the association between COPD and air pollution, although the issue with this study, which is excellent and is very well set up, the issue with that is that you need to exclude everything else. So let's say, okay, you live somewhere where the air pollution is X, and you live in a place where air pollution is X, and let's see the two things, but then you have to start excluding anyone that is a smoker, or an ex-smoker, or has worked in a place where they've been exposed to passive smoke, or to any sort of hazardous gases for work, and so on. So the setup for the study is fascinating, it's very good, it's very well run, and so on. But trying to find a relevant number of suitable candidates across the UK in order to have a study that people would read and go, oh, there is a correlation as such, it's proven particularly difficult, but I've got great hopes. Genetic abnormalities, it counts for a small percentage of our patients with COPD. Although I will ask you to keep in mind for now, the alpha-1 antitrypsin enzyme is something that we're going to recall in a bit. So a deficiency of the alpha-1 antitrypsin enzyme, the genetic condition itself is quite rare, although this is a big player in our COPD, and we're gonna cover that later on. Okay. It worked. I gave myself. Here we go. So, all right, see how it goes. See, I see the difference, it's so much better when you... I get it, all right. So what we've got here is a section of an airway. So we talked about COPD being a combination between these two conditions, yeah? Chronic bronchitis and emphysema. So let's talk about exactly what are these two. So here we're going to go through chronic bronchitis. So we've got a section of an airway here. It looks terrible because I can't draw. But what we've got a relatively healthy airway, no swelling there. We've got some nice, relaxed, smooth muscles. What's missing here? So what's missing from this airway is a nice, healthy layer of mucus. Okay, here we go. I tried to find the most mucusy yellow I could find. I actually embarrassed. I don't know how long I thought, which one is more mucusy? Right? Shall I go for green? Anyway, so as we said, a layer of mucus in your airway, it is normal for your airway for what? You mentioned it for asthma. Someone mentioned it. What do you need mucus for? What was that? Absolutely, to trap pathogen and then eventually getting them out. Yeah. So when it comes to chronic bronchitis, so anything that finishes with itis is an inflammation or something. Yeah. So we really very much revert to what was our inflammation lecture last week and earlier on with asthma. So I've got chronic bronchitis, and one thing that happens here is this. So I've got here these. Here we go. These little glands, little green glands here. Here we go. These are mucus glands that we've got just on the side of our airway, yeah? Now, we said that that's not the only thing that secretes mucus. What did we say also helps secreting mucus? Goblet cells, absolutely. So they are here we go, quite similar. Here we go. So little cells actually going around here. Here we go. So your goblet cells around there, and that's what they do with your secretion wall. So when it comes to the mucus secretion for COPD, that's what we've got. We've got hyperplasia and hypertrophy. Of mucus glands and goblet cells. Okay, so if I've got hyperplasia, what did we say hyperplasia was? Loads, lots of them. So they do replicate a lot more. Okay, so I've got of this green. Here we go. You look like a goblet cell green. There we go. So there's a lot more of these. Here we go. And hypertrophy, what is it? Absolutely, they get bigger, really, yeah? So what happens if I got hyperplasia and hypertrophy of mucus glands and goblet cells? This is what happens. You get an enormous amount, there you go, of mucus accumulation around your airway. Okay? And here we go. Causes mucus accumulation. So my U's look like V's, I don't know why. Here we go. So that's it. So there is a scientific mystery. I have no idea why, but my U's look like V's. Here we go. Or Roman 5s, you know. So that is one of the main things that we need to talk about when it comes to chronic bronchitis. Now, the next thing is quite interesting. So the lining of our airways, they're all lined with these guys. Any idea what they are? Absolutely, they're ciliate cells with a little cilia on top, yeah? So they've got this little like hair or pilis on the top of it. And what they do in a well-functioning airway, they are supposed to get, there we go, a little layer of mucus on top, Here we go. And then they catch, that's it, that looks like a pathogen. Here you go. They catch the occasional pathogen on the mucus. And then the movement of the cilia, it literally goes like this movement up and down. That's what we called the mucociliary elevator. The mucociliary elevator, that is what moves the mucus up the airway and then leads to excretion. Okay? So here we go. See, again. Good stuff. So what's going to happen at this point? At this point, there's two things that happen. And it's quite interesting. Because of my initial hyperplasia and hypertrophy of my goblet cells and my mucus glands, what's going to happen to this nice, fine, manageable layer of mucus? Absolutely. It's going to be a lot more, isn't it? So we said that is quite a lot. Actually, you know what? I'm going to do a little big mucus. Here we go. Big layer of mucus. Here we go. So we've got a much bigger layer of mucus right on top of my ciliate cells. Now, that is quite interesting though, because it works at three different levels. First, the mucus, there's too much for my cilia to be able to manage it. Yeah? So my mucociliary elevator system is compromised, firstly, by the sheer amount of mucus that they have to deal with. So that's just not working because there's just too much of it. The second thing is that if the mucus doesn't move, where does all this little pathogen go? Huh? They just stay there, isn't it? They don't go anywhere. So there's actually a risk to form what's called a nidus, which is Latin for a nest, of pathogens. So potentially, this pathogen is going to stay there and say, well, you know what? If this is my new home, why not? I'm just going to proliferate in here in this very mucus-filled environment. Why not? Because pathogens do that. So that is the second layer of risk. That's why really I can't really get over this inflammation, because there's a constantly accumulation of pathogenic material that it keeps on getting onto my immune system. But the third thing as well, which is quite interesting, is the irritants that go into my body. So we talked about, well, let's say cigarette smokes actually is one of the prime culprit for this, or other irritant sprays or gases. What they do, they literally cut those cilia. So they make them shorter. So there is a direct damage to the cilia of my ciliate cells, so that with shorter villi, they can't move it because they just can't reach it as such, right? So, hold on. Colin, where's your eraser? Oh, here we go. I found it. Let's go. So here we go. So your irritants, what they will do, they will sort of cut some of the cilia like that, okay? Damage. Here we go. So when it comes to, we said, okay, well, there's just a lot of mucus. And as you can see, there is quite a lot of different levels that we need to think of. Yes, there is a lot of it, and that already start causing some level of obstruction into my airway, a mucus plug and so on. Yes, but also I'm now unable to get rid of a lot of the pathogens that get trapped in there. And thirdly, the actual irritants that caused all this are also literally chopping off some of the only elements that I have in order to get rid of this. And that's why this accumulation continues in a sort of an endless loop. Next thing that we're going to look at is this. This is the end of an airway. Yours was better. Give you that. It's the end of an airway. Yes, yours was slightly better. All right. Give us a break. I tried to do this while on a train while holding a 2-year-old. Hence, I draw like a 2-year-old. So, when it comes to this point, here we go. We've got this mucus. They form this. It's like that. Okay? All over my airway, like this. And this is what we call, surprise, surprise, a mucus plug. What is the consequence of this? You can't, yeah, absolutely. So the coughing will be relentless. Unfortunately, though, the coughing, other than the actual spasm of the muscles, without the assistance of your ciliate cells, it's not working a great deal. So the coughing will be horrible and continuous, but it's not going to work very much. So that mucus plug actually, to some degree, it's going to stay there for a bit. So what are my effects? So I've got a terminal end of my airway here. So what might this impact if I've got a plug in it? Huh? Absolutely. So I've got some narrowing of the airway here, right? So it's going to impact how much oxygen goes in, for example. Yeah? Fair enough? So reduced O2 going in. And what's going to happen to the CO2 trying to go out? It's just going to be stuck in there, isn't it? Because it's going to reach here and then it's going to try to go around here, but not as much as going to be able to go out. Yeah? So we're going to have an increased partial pressure of CO2. Brilliant. So, if I've got a lower level of oxygen, how do we call that? Low oxygen. Hypoxia. Yeah, so this can cause hypoxia because I can't get enough oxygen in. So, is that iron? Yeah. Huh? Yeah, I thought so. Oh, I doubt myself. Yeah, fuck off. Like, how about when there's a high level of CO2 in there? Hypercapnia. I don't want to spell it in front of 50 people. Dude, what's that? Tell it to stop. No, it's fine. I got it. Hypercapnia. Yeah? That's right. Looks about right. Okay, see, that's the problem with these things. I don't have the spell check, do you? Okay, so we've got hypoxia and hypercapnia that is caused by these mucus plugs that we've got. Now, there is something else that is happening here. So because I've got less, aside of the fact that I've got CO2 that can't get out, right? And yes, we're talking about oxygen coming in and oxygen coming out, but also I'll have loads of air that is left over inside my alveoli, yeah? And this is what we refer to as air trapping. So, Your chronic bronchitis will be a big accumulation of mucus due to the hyperplasia and hypertrophy of your mucus cells and goblet cells. Because I see it fine here, but I want to make sure that you guys see it fine as well. You have an impaired mucociliary elevator due to the amount of mucus, to the damage to the cilia due to the irritants, and you have a permanent, amount of pathogens there on the cilia itself. And because of the mucus plug cold, the mucus plug that you develop, I've got less oxygen going in, less CO2 that is managed to be shifted out, and then in chronic bronchitis, I can get hypoxia, hypercapnia, and obviously air trapping at the bottom of the lung. So despite the infantile and let's say quite puerile drawing, is that clear enough? Yes.
Is that why they give carbocystine to try and move the mucus plugs?
What was that?
Is that why they give COPD carbocystine to try and
Yes, absolutely, to try to shift it. Absolutely. What it does more, it tries to, I'm going to say liquefy it a little bit, but to try to weaken it, this plug, and try indeed with a cough to try to get it off. Okay, and that is what your chronic bronchitis is, which is only half the battle really on your COPD. The other thing that we've got in COPD is emphysema. What is emphysema? So this is actually relatively a bit easier to explain. So I've got my alveolus here, okay? And let's say I get, here we go, make them a little bit bigger as well. Here we go. I've got all sorts of irritants getting inside my lungs. Okay? This could be your cigarette smoke or whatever. When all these pathogens of all sorts, whatever, they get inside my lungs. So referring back to Colin's lecture really last week, one of the first things really that will attack this is not just a systemic response, but I will sort of start getting some macrophages in there, yeah? They need to get right in there, so hey, I'm gonna eat myself some of this irritant, all right? So you do get some macrophages, the gobble of my... Well, Colin, I can't hear you from down here. It's not a what?
Nothing, it looks great.
Thank you. I thought so. Actually, you know what? Just because of that, I might just have one that just ate one. And it's very happy. So got your tongue out for it. Here we go. So you've got your macrophages. So you've got your macrophages that will start... Yeah, we get it. The cough and then mucociliary elevator and all this. Are you okay? Would you like some water?
Okay.
You sure? Okay. So, okay, fine. I'm gonna actually label it just in case. So this is my pathogen or irritant. These are definitely macrophages. Damn it, so close. Okay, so did we say that it happens once your macrophage assimilates a particle antigen? What does it do? They're going to start releasing some cytokines, aren't they? And they're going to start releasing information instead of, it's sort of a need to start releasing some sort of information on what's just happened. Okay, so we've got some. Here we go. So here. These cytokines, they will sort of message who? Well, they're going to message our good old neutrophils to do the same thing. Neutrophils are like a purpley kind of thing, aren't they? I don't know. They look purple to me. Here we go. They release neutrophils. in large numbers. And at this point, that's where it becomes interesting. Neutrophils will then release all sorts of different proteins, but also proteases. And a protease is like an enzyme, is a substance that destroys proteins. And you can understand why. I mean, they are part of our immune system. They need to destroy things. Yeah? They need to get something and need to destroy. But one of the proteases that they release, it's called, here we go, elastase. Give me a decent white. Here you go, you'll do. Now, as you noticed, I drew like some sort of a thin layer around my alveolus. That substance around your blood cells is what we call elastin. Okay? So, how does elastin work? So, imagine this as being, look at that, it's very similar, right? So just imagine this as being the air of my alveolus, okay? So I'm going to breathe in, right? Right? And that's what's going to happen. And that's exactly what happens. My breathing out is like a passive motion, and this balloon wants to return to its normal shape, yeah? So again, I breathe in, and then eventually, as soon as the valve activates, it's going to come out. This balloon is elastic, is rubbery, and that's exactly what happens around my alveolus. And the property of this happening is due indeed to elastin. Okay? So, here we go, I'll just put it. Elastin. Sure. Elastin enough. So, what do you think elastase is going to do? It's going to start breaking down elastin, okay? But it doesn't matter. It doesn't matter because usually in a healthy body, I have another enzyme that is produced in my liver, right? That will counteract this action, okay? Which is the one that we talked about earlier on. And here we go. Boom. Boom. Oh yeah, fair enough, you can't see that. I'm an idiot. Sorry, I had a bit of a moment. So anyway, alpha-1 antitrypsin, okay, is the one earlier that we mentioned earlier on. So alpha-1 antitrypsin is an enzyme produced by my liver that what it does, regulates my elastase. Okay, so elastase gets produced, does what it does, but attacks elastin. But I've got this enzyme produced by my liver that's got to, hold on a minute, you're going to start attacking the lungs here. That's not good. So what it does, alpha-1 antitrypsin is going to bind to elastase and sort of deactivate it. And that's fine, yeah, that's a normal regulation of our body. The problem with that is, though, is indeed the irritants that are getting in here. If part of this irritant is cigarette smoke, what it does, cigarette smoke, it binds to alpha-1 antitrypsin, okay, which is an incredibly important enzyme because that's the one that makes sure that your lungs stay elastic, produced in the liver, as I said. Cigarette smoke binds to alpha-1 antitrypsin, and it sort of doesn't deactivate it per se, but it binds it at the bottom of it, to one of the amino acids at the bottom. So when it tries to attach to elastase, it bounces off it. So because of my constant exposure, for a smoker especially, to cigarette smoke is one of the main culprits for it. There's other irritants that will do that, but not to the same level. Cigarette smoke will bind to alpha-1 antitrypsin, which is this enzyme produced in the liver to counteract the action of elastase that will start eating into my elastin here. Cigarette smoke will bind to it, and it's just gonna make it stop working. So at this point, I've got nothing regulating the production of elastase. My neutrophils get produced. Of course they do, because it's an inflammatory reaction and neutrophils need to be called to action. Because I do have pathogens coming in. Because they said there is nothing that will stop the cytokines from my macrophages being produced. Neutrophils go in. They produce, amongst many other proteases, this one that will attack the lining of my lungs, the elastic lining of my lungs. And when you get to this level of damage, when elastase production is out of control, and I'm starting to get quite a lot of damage around here, around my elastin, just like that, well, I'm no longer going to have a balloon when it comes to inflate it. I breathe in and that's it. It's not going to deflate again. Okay? That's exactly what's going to happen. This is a non-elastic kind of structure. It fills up with air and it stays like this. And this is what happens to the alveoli of someone that has a relatively advanced emphysema at this point. My elastase keep on attacking the elastin. My body is no longer able to regulate it because my alpha-1 antitrypsin is unable to regulate elastase, and I'm losing the elasticity in my alveoli, causing, I'm going to try to get some air in, but then trying to push it back out, I just can't, because I don't have this level of elasticity. Amongst other things that keep my alveolus open like this. Yes, elastin is one thing. I've got collagen as well that keeps everything open. And amongst my proteases here, I have elastase, I've got collagenase as well. Why? Because bacteria on their membrane, they've got exactly the same thing. And I need to break it down. So my body goes, it's fine. I'm going to produce all of this stuff. It's going to kill all the bacteria, but it's cool. I've got alpha-1 antitrypsin to the rescue. It's just going to stop binding and sort of stop attacking my lungs. But obviously, if that doesn't work, yes, it's going to start degrading loads of the bacteria, antigens, and all sorts of stuff that get in my lung, but also will start attacking my own body with no ways really to regulate that anymore. And this is what happens in broad terms in emphysema. Does that make sense? Yeah? Good. Excellent. So, no, wrong. This one. Wrong. Man, I'm a technotard and a half. Hey, sorry. So, here we go. So that's it, really. Does that make sense, the difference between chronic bronchitis and emphysema? Yeah. So of course, all of that will eventually cause as well some hypoxia and some hypercapnia, your emphysema as well. But it's a very, very late sign of emphysema. When in a patient with COPD, they do have these kind of clinical features, is often due to your chronic bronchitis more than the emphysema itself. Much later stages, pre-terminal stages, yes, it gets so bad that your alveoli are just inflated sacs, but they're not supposed to be inflated all the time. So they become very fragile and they can actually rupture very easily. And that's really, you'll start getting your final stage of COPD where really you can't take much of a breath at all. The rest of it is a little bit of a summary of what I just said. So chronic inflammation causes hyperplasia of mucous cells with and chronic asthma patient, etc., etc. That's your persistent airway inflammation is known as chronic bronchitis, and damage to alveoli from inhaled irritants is known as emphysema. Here we go. This is a much better drawing than what I did, but it made sense in my head. Just nice. I hope it makes sense in yours as well. Here we go. So this slide is literally just a bit of a summary of what I just said about elastin. It's all in here just for you guys to see when you revise what is elastin and what it does. Now, this is another diagram like the one for asthma. It's all in here, guys. Just study that. You'll be all right. Yeah, up to a point. Obviously, I understand. So what we're going to do, just very briefly, we're going to go through it. But again, it's in broad terms what we just said. So genetic susceptibility So alpha-1 antitrypsin deficiency, as we said, it can be very, imagine if you don't produce that at all. You know, that is bad. Your body will actually start attacking your elastin quite early on in life, and without you having had spent 25 years smoking, you know. So you get all the damage with none of the pleasure, you know. So that's such a shame, you know. And obviously this would, but it's quite rare. It's quite rare. So this obviously reduces the lung's ability to prevent damage to lung tissues. So everything is going to get damaged anyway. Environmental insults to lungs, so long-term smoking, pollution, infection, etc., etc. Free radicals produced in lungs. Your free radicals are like oxidative atoms of any sort of pollutant that is not good for you, okay? And inactivation of lungs antiproteases. This is what we were saying about, let's say, the cigarette smoke that damages, that binds actually, to be perfectly clear, it oxidizes a bit of your alpha-1 antitrypsin and makes it impossible to bind to elastase. Okay, so that's what it is. So your long-term smoking inactivates your antiprotease defenses. What this happens, what leads to, obviously, to lung inflammation, oxidative stress, and inflammatory cytokines that get released, as we said, and protease function. And that's it, really. There is a continuous injury of your bronchial tree, infiltration of inflammatory cells, especially neutrophils. Here we go. You got airway fibrosis and narrowing that point because of your inflammatory reaction, your globulate cells proliferation, mucus production, etc., etc. This is your chronic bronchitis. That's your emphysema. We literally just went through it. So that is trapping of air within the lungs, airway narrowing and collapse. The collapse of the airway itself is a later kind of stage. But eventually, if the structural damage of your airway is sustained for long enough, so there are loads of damage to your elastin, loads of damage to your collagen, eventually it will just go, and that's it, really. Or you can get these hyperinflated lungs, and the bullae, which is like this constantly inflated cluster of alveoli, really, they can just burst because they become incredibly fragile. They're not supposed to do that. It's like if I was to the balloon that I had there, so if I keep it inflated all the time, eventually, you know, the structure of it, the elasticity of it will not work anymore, eventually would burst, okay? And that's your emphysema. Happy with chronic bronchitis and emphysema? And what they do? What they are, yeah? Yeah, good. I get good nods. Excellent. Brilliant. So the terminology here, respiratory failure. There is two types. We talk about respiratory failure. So that's two types of respiratory failure that we have. They're not necessarily only related to COPD. Okay, a respiratory failure is a broader term for all sorts of respiratory conditions that cause what? Well, type 1 respiratory failure is hypoxemic respiratory failure, which means that is associated with, well, acute disease, pulmonary edema, etc., which means that it leads to a low level of oxygen in my blood. That's what it is. I'm unable to get sufficient oxygen into circulation in order to perfuse my tissues, my brain, etc., etc. That is what a type 1 respiratory failure is the patient will be hypoxemic, and that's where the damage comes from, for a failure to perfuse my tissues due to whatever it is condition that you have, whether it's COPD or pulmonary edema or whatever. A type 2 respiratory failure, instead, is a hypercapnic respiratory failure. What does that mean? Huh? Absolutely. That's too much CO2. That is when we've got like a retention of CO2 and I'm unable to shift that CO2 back out chronically. Yeah? That is what your type 2 hypercapnic respiratory failure. Often, but not always, and a type 2 respiratory failure, you're also hypoxemic beforehand. And it's sometimes, and I cannot stress this enough, sometimes seen in COPD but not always. Okay? You do get some chronic CO2 retainers in COPD, but we are talking about a relatively small percentage of them over the whole population. Okay? So sometimes it's seen in COPD, hypercapnic respiratory or type 2 respiratory failure, sometimes seen in COPD, but not always. So when it comes to the treatment of COPD, and here, guys, before we go into actually making bold statements on a huge wall, we're going to be talking to you guys as adults and as thinking clinicians, okay? So we are moving away from being technicians or paramedics by numbers, okay? It's not because, Chuck Cox says this, that's why I'm going to do it. I'm going to talk to you as thinking clinicians. So I'm going to say certain things here in order to make you think of the pathology of the condition, okay? That means that you need to think about your treatments, but don't just jump to conclusions, okay? So, easy to say if I say that excessive oxygen administration can lead to hypercapnic respiratory failure in some COPD patients. The last thing I want is half of you guys in here goes, cool, no oxygen to COPD patients. Sounds about right. Yeah. Otherwise, just God forbid they get too much CO2 in there, okay? Because that's not at all what we're saying. So I'm hoping they're addressing a thinking audience and try to extrapolate from this what is it you need to, okay? COPD patients with the most severe hypoxemia are indeed at risk of CO2 retention, but is a relatively small population in comparison, okay? And this can lead to CO2 retention with excessive O2 administration. Why am I saying all this? Why am I saying? Because I have been taught all sorts of bollocks about COPD when I first trained. I'm sorry, but that's the only way to say it, isn't it? I always said, yeah. You don't give too much oxygen to COPD patients. Poof, mind-blowing. Why? And the whole thing was about, it's because they're used to not breathing very much, So their hypoxic drive is kind of a different at that point. So if you give too much oxygen, they stop breathing. Boom. You say that, I believe it. No problems. Great. Anyone else been told something like that? Yes. Okay. Well, that is not true. That is just, that is a lie. That's what we have been told, okay? So this is your traditional explanation of COPD. It's a very good, quick way to say, okay, if you give too much oxygen to COPD people, they'll die. So don't give them too much oxygen. Okay, 6 minutes maximum. No bother. Okay, like religiously. 6 minutes, otherwise they'll stop breathing. Okay? And that's what I go through. Okay, but then you decide, how about I start thinking about my treatment? One, where did that 6 minute comes from? Have you ever found out in the end? I have absolutely no idea where 6 minutes. There is absolutely no evidence base in any of this whatsoever. What is hilarious, I was reading a bit on Life in the Fast Lane on it, and whoever wrote that just went on a rampage about this is why it's silly to teach people that kind of thing, and lists a magnificent list of why is it not true, why there is no evidence towards this, and why we shouldn't be taking this as a fact, okay? So, your respiratory drive, per se, which I'm assuming it was something directed to your chemoreceptors on your aortic arch. That's how it probably was trying to explain as such. Well, they have nothing to do with your pulmonary circulation. Oh, well, they do, but it works in the opposite way. So no, they're really not related in that sense. So that didn't make any sense at all. There is, though, a basics of truth in the sense that, yes, CO2 retainers, they can get worse if we administer too much oxygen. Fair. But why? So, This is what Colin went through this morning. So these two are like two factual statements that Colin has explained this morning. During your hypoxic pulmonary vasoconstriction, high partial pressure of O2 at the alveolus level causes arterial dilation. Okay? Happy with that? Because I've got big ventilation, therefore I need big perfusion, and in order to get big perfusion, in order not to have this mismatch, I need to have vasodilation. Fact? Are we happy with that? Cool. If that's not factual, his fault. But fair enough, it makes sense, doesn't it? In CO2 retainers, the effect of air trapping, which we just covered. Why does that happen, your air trapping? Because of your reduction of elastin, because of your mucus plugs, etc., etc. The effect of air trapping means that carbon dioxide is not ventilated out of the lungs, leading to quite a high partial pressure of O2 in my alveoli. Yeah? So I cannot shift, see some confused faces there. So I cannot shift my CO2, I can't breathe it out. So there's air trapping, and let's think in this way, all that air is trapped, is not going to be oxygenated, is it? There's a lot of CO2 that remains trapped inside, which means that the partial pressure of carbon dioxide at alveolar level, if I'm a CO2 retainer, it's quite high. Yeah? Okay. Now, this is good. So in COPD, my normal patient, what we'll do, my patient will optimize their gas exchange by hypoxic vasoconstriction. What does that mean, really? So it means, in order to maintain this ratio, if the partial pressure of CO2 really is quite high, or really if my partial pressure of oxygen is quite low, what I'll do, because they are O2 dependent in this case, isn't it? I'm just going to get vasoconstricted. I'm going to have less perfusion, yeah? So ventilation goes down, and because I'm not very well ventilated, so I'm going to get vasoconstricted, and I'm not going to get as much blood through that, in order to maintain this VQ ratio. Then we come along, okay, and we decide to give a whole load of oxygen, like 15 liters of oxygen for ages, you know what I mean? Ooh, you're not looking very good, just have this, you know what I mean, for quite a while. Trauma mask and everything, and we're going to give a lot of oxygen to this patient. Now, what's going to happen? What's going to happen in this situation, that the level of oxygen is going to go up, because I'm just forcing a whole load of O2 into my patient. So the partial pressure of oxygen is going to go up. But is the ventilation of my patient going to get any better? Huh? No, you're right. I still cannot shift that CO2, can I? It's, oh, you gave me some oxygen. That's it. Finally, that's the stuff. You know, that's right, what I needed. You know, and good old oxygen makes me breathe better. Well, I know it doesn't, does it? It increases the percentage of oxygen, but it doesn't make the ventilation any better. So at this point, what I end up having, I'm going to having a very low ventilation, but I now just tricked the amount of partial pressure of oxygen to go up the way. So what is that going to cause? It's going to cause some vasodilation. Now at that point, because my body thinks, oh great, we are getting loads of oxygen in here, right? Boom, big perfusion of my alveoli, but I still poorly ventilated, which caused this VQ mismatch that Colin was telling you about. And that is the problem. That's why we try to give salbutamol as well to my COPD patient if they have it, their combi vents, together with my oxygen therapy. Why? Because not only I'm trying to give them some oxygen, absolutely they need that oxygen, but they also need to start shifting that air. Yeah? Because if they don't shift that air, I'm just not going to help as much. Okay? Does this make sense? Yeah? This is why, because we do not want to increase the VQ mismatch. We do not want to increase the dead space. That's why we limit the amount of oxygen that we can. Actually, there's a terrible word, though, saying limit oxygen to CO2. It almost as we're holding it back. So what do we do? How do we compensate for that? So we're not going to give them like 15 liters of oxygen for 2 hours. Okay. So how do we compensate for that? How does the thinking clinician act in this case? What do we do for COPD patients then? Titrate. So we titrate the amount of oxygen that we give. But we titrate it to what? To 100%? Did you say 28%? So, oh, I see what you mean. Okay, no. I thought you meant like the level of oxygen to the patient. You mean, if you get a SATs of 28%, you go, yeah, that's just about right. That's just a spot. No, fair, okay, no, I see exactly what you mean. Absolutely. So we have things like Venturi masks. We've got nasal masks. Absolutely. So we're going to titrate it to effect, and we're going to titrate it to a lower saturation. That's how we mitigate this risk. Yeah? So we will mitigate, we will sort of get it between 82 and 94%, between 84 and 92% of saturation for this reason. And we do titrate indeed to effect. But once I reach that level, that's when I might want to start toning down my oxygen a little bit. So in all of this, did I say at any point, do not give oxygen to your COPD patient? No, I did not say any of that, okay? And absolutely give oxygen to your COPD patients. They need it. Sometimes they're just not going to reach that 84% number, or they might never reach that saturation. So does it mean that I have to keep it just for 6 minutes? I know that you're still at 76, but it's about 6.5 minutes now. So I might just give it back. No, I'm just going to take this mask off you. Thank you. Do I do that? You can if you want to. You're your own clinicians. It's like before. I'm not going to argue with you guys. You do on the road whatever you want. But now you know the consequences, okay? But now I want you to think about what is it that you're doing. I want you to the next student that you're going to be in with and say, well, listen, I know they might be told you to keep it to 6 minutes. I'm going to keep it a bit longer, and that's the reason why. Because I've got a target, and that's the target saturation I'm going to go for, okay? And this is why we limit the amount of oxygen that we give to a COPD patient, but we don't take it away from them, okay? If you find out where 6 minutes comes from, let me know. I don't know. I looked everywhere. I couldn't see. I think someone at some point tried to explain me it was some sort of derivatives from somewhere, but it was purely anecdotal. Okay. That's the answer that you get, isn't it? So that's what Gerald Calc says, but I have no idea where 6 minutes come from. The thinking clinician knows that too much, of course, is not going to be good for them for that VQ mismatch situation. But also the thinking clinician knows that without oxygen, my COPD patient that is very unwell will die, okay? And we are not going to be those guys, okay? Any questions? No. Okay. I'm almost done. So the next bit is the Haldane Effect. Who remembers it? We talked about it. We talked about it week one already. Seems already a long time. You say, well, week one, what's that all about? You know what I mean? Just go. So we talked about a Haldane Effect in week one. This is one of those things that, how can I put it? By reading all of these things over and over again, just to make sure that I don't come here and be the guy that when you guys are going to be lecturers, I'm not going to go, in my paramedic course, I've been told all sorts of bollocks about COPD. You know what I mean? So just to make sure that that doesn't happen, obviously, you know, we've been reading quite a lot on all of this and make sure that everything is well research based and so on. And I found understanding well the Haldane Effect helped me and said, I get it a lot better. I understand it better. This is not something I would put 5 questions on an exam about a Haldane Effect. I might just shove a cheeky one in there, you know. But if you really can't wrap your head around it, don't panic about it, okay? But I thought it would be almost mean for me not to go through it with you briefly, because it helped me a lot to understand all of this. So maybe just 1% of you guys will help you understand it or not. So I'm just going to go through it quite quickly. The Haldane Effect is, we talked about in week 1, we talked about hemoglobin and hemoglobin dissociation. So hemoglobin was going around with its oxygen, you know, it goes and adds some time, so it gets to the tissues, and gives away its oxygen. okay? And that's what it does, and that's how it talks, all right? So, and we said that when it comes to the tissues, the Bohr effect, so when there's a higher concentration of CO2 in the environment, hemoglobin loses the affinity for oxygen and makes it go away, which is good, which makes it perfuse to the tissues. But then we also said, briefly, admittedly, and you will find in one of the very last 2 slides on week 1 at the very top, but we also said that when my deoxyhemoglobin comes back towards the lungs, a high concentration of oxygen in that environment makes my hemoglobin, the affinity of my hemoglobin to CO2, a lot less. So it's much more likely to let go of its CO2 to grab some oxygen in an environment where there's a lot of it. And that makes sense, doesn't it? Because in my lungs, for example, in areas with loads of oxygen, that's what I want hemoglobin to do. To just go, oh, look, oxygen, love it. And just get rid of CO2 so that I can exhale it out. Okay, and that is the Haldane effect, literally in a nutshell. We'll talk about the right shift in the dissociation cost. So in patients with severe COPD, you cannot increase minute ventilation. So we talked about, I'm going to give a lot of oxygen to my COPD patient, but we also said that my COPD patient with only oxygen is not going to breathe any better, are they? They're not going to shift all that CO2 any better. And that's why, really, what happens to my COPD patient when I give excessive oxygen as such is indeed because of the Haldane effect. Now, this is what's called the CO2 dissociation curve. At the bottom here, you have the partial pressure of carbon dioxide, and here, how much carbon dioxide is bound to my hemoglobin. It's when we get to the point of we give a lot of oxygen, the rightward shift, that's what we mean. Like on a saturation of 100%, that's what we mean. And it's okay, but it's easier to understand here. This is my oxygen dissociation curve of hemoglobin, and we briefly covered it on week 1, okay? So here, as I've got loads of oxygen, partial pressure of oxygen here, 100%, that's my lungs, okay? That's one here is on my lungs. At about 50 millimeters of mercury here, about, let's say, my leg muscles, okay? It's what here, all right? And this black curve is my hypothetical, nothing happens in my body, and this is how hemoglobin would start letting go of oxygen in my tissues in normal circumstances. And these other 2 curves here are explained. So if I've got reduced oxyhemoglobin, higher CO2, lower pH or higher temperature, there's a shift here. Or when there's lower CO2, there's a shift on the other side. Let's have a look. So let's say at 50 millimeters of mercury of partial pressure of my oxygen. What happens? In an ideal circumstance, so let's say I started at the lungs, okay? Here we go. So if we're looking at the black lines right now, it gets to what? 80%, which means that I started with 98, let's say. It's at a maximum amount of saturation of hemoglobin is 98%, really. So 98 to 80%, which means as soon as I get to my muscle cells here, how much oxygen I've given out? About 12%. That's not a great amount, is it? It's not great. So what do I need? I need an environment that is far more acidic, far less pleasant for it. I need something hotter, something more acidic, and I need something with more CO2 in order to increase the amount of oxygen that I release. So look, when I've got higher CO2, I already get to about 70%. Yeah? So which means that with higher concentration of carbon dioxide, my oxygen, there's a lot more oxygen that gets released by my hemoglobin. Now look already the difference. Here's about 12%, here's like, what, 30%? of my oxygen and it's been released, and so on and so forth. If I was to give loads of oxygen to my patient and he just cannot shift any of it as such, so I knock down my CO2 a lot, what's going to happen? How much oxygen is going to get to my tissues? About 10%, if that, which is not a good thing. Okay? And this is like your Haldane effect. It's fine if you now look, I have no idea what you just talked about. And it's fair. It's absolutely fair. Okay? It's the kind of thing that you need to have a look at it and you go, hold on, what? And then follow the little line and go, what? And then you follow the line again, you go, what? And then eventually it clicks and you go, oh my God, the whole lecture makes sense now. Right? Seriously. If you can't wrap your head around it, don't worry about it, okay? But I found it quite particularly useful to understand. So, the management of your COPD patient, target between your SATs between 88 and 92% in these patients. The targeted approach is associated with decreased mortality in COPD patients. So really, this number is not been pulled out of nowhere. It's been researched. Here we go. And the oxygen flow rate administered is not important. But what the partial pressure of O2 that you achieved, it is. So you're limiting to 6 minutes. There's no scientific evidence around it. Okay, your Venturi masks, which you're going to cover in your part 2, or you should have covered it already and so on, they are helping you to titrate that. Your nasal cannulas, they are helping you to titrate all of that. So really is your end result. That's what you want. Never we had this, obviously we finish on the whole. Never withhold oxygen from a seriously ill hypoxic patient due to fear or cause hypercapnic respiratory failure. If they need oxygen, they just need oxygen, okay? And that's nothing worse. You go, no, that was 6 minutes, get away, get off my oxygen. You know what I mean? No, you don't get any, okay? That doesn't make any sense. And there is no scientific base around it. And that's it. That's COPD. Kind of makes sense?